Hello, and welcome to today's virtual program hosted by the Healthcare Council of Chicago, HC3. My name is Megan Phillip, and I am the Executive Director of HC3. We are a mission-driven platform proactively seeking uncommon alignment to improve Chicago's healthcare ecosystem. As we continue to navigate the ongoing COVID-19 pandemic, HC3 launched the Transformation Series to address how we can leverage our collective resources to foster solutions and help rebuild our communities. On one of our priorities of these Transformation Series events is to consider how we get back to normal. As part of a two-part event kicking off today, I'm so grateful to HC3 members Jarrard, Phillips, Cate, and Hancock, and Radiology partners for co-hosting our Safe Return to Care events. And I'm especially grateful to our partner, the American Medical Association, for joining us today to lend their expertise as we kick things off to take a deeper dive into the 2020 Coping with COVID-19 for Caregivers Survey. Before we dive in, there's just two housekeeping announcements. This afternoon's discussion will be recorded and shared on our website, www.hc3.health, for later viewing and sharing. As we hear from today's experts, if you have questions, please feel free to use the chat function, which will be seen directly by our moderator, who will do her very best to address them during our audience Q&A. Later in the program, we will be joined by Dr. Chris Mattern, Practice President of Greensboro Radiology and Associate Chief Medical Officer for Radiology's Experience at Radiology Partners, as well as Dr. Mark Winokur, a Principal Behavioral Health Segment Leader at Chartis Group, with our discussion moderated by Molly Cate, Founding Partner, Chief Innovation Officer at Jarrard, Phillips, Cate, and Hancock. But it is my absolute pleasure to kick off our sort of feature presentation with Kira Cappellucci, who is the Project Administrator of Practice Transformation at the AMA, to join us for her virtual presentation. Kira?
Great. Thanks, Megan, for that introduction. And I'm delighted to be with you this afternoon. I'm going to share my screen so you can see my slides. So I'm excited to share some of the work that we've been doing at the AMA over the last year around clinician well-being and burnout. I'll be sharing some of the high-level findings from our COVID well-being survey, and I'll also spend some time sharing with you some of the solutions or action steps that health systems have taken in response to the data that they've received from the survey. But just a bit of background first. The AMA has been working with health systems for a few years now to provide burnout assessments and really serving as an advisor to health systems wanting to build out strategy and support around wellness and burnout. And so when COVID became our reality last year, we developed a new assessment tool so that health systems and practices could measure the impact that COVID was having on the well-being of their workforce in real time and respond accordingly. And so that's what became our Coping with COVID-19 for Caregivers Survey. This was a 20-question tool to measure things like stress, self-reported anxiety or depression, burnout, and also to capture potential solutions for health systems to enact. We opened up the survey to anybody who wanted to use it. It was not contingent on any costs or AMA membership. So any group that wanted to use the survey received a unique survey URL that they could deploy to their workforce to collect survey responses. And they also received access to a unique reporting dashboard so that they could review their results. The data that I'll be sharing with you today comes from just over 85 healthcare organizations representing over 200 individual hospitals or practices who have surveyed from early April of 2020 through the end of 2020. We are still collecting data on this survey, but what I'll be speaking about today is our 2020 data. And one small note I want to make is that this survey was open for both clinical and non-clinical staff. We did not dictate who organizations sent the survey to, and I would say the majority of organizations sent it to everyone, so both clinical and non-clinical staff. But I just want to note that on the front end that this was not specific for just clinical or medical staff. So just a quick look at demographics. You can see who makes up our convenience sample. We had 67%, so almost 70% of our respondents who identified as female. and 64% who identified as white or Caucasian, so a large grouping of white or Caucasian females in our sample. We also asked individuals about their role type, and about a third of our respondents are coming from physicians, 20% are coming from nurses, and just under 20% at 17% are non-clinical support staff. And we grouped any non-clinical role into this non-clinical support staff category. So we have about 1 in 5 that are non-clinical. We also asked about practice setting. This was a multi-select question since we know that people work across a variety of practice settings. And about 35% of respondents came from hospital-based non-ER, non-ICU settings, and 35% came from ambulatory-based settings providing non-COVID care. So 70%, or about the majority of our sample, were not providing COVID care over the past year when they completed the survey. So I'm going to share just a few high-level findings from our data. This is certainly not comprehensive. There's a lot of information that we've gathered from our data, but I'm hoping this will give you a little bit of a flavor of what we've seen, especially over the past year. And I'm going to start with burnout. So we use the single item validated mini-Z burnout question. This has been validated against the Maslow burnout inventory several years ago, and it simply asks respondents based on their own definition of burnout to choose where they fall on the scale. We consider burnout anything that you see in the red, orange, or yellow. So that's individuals who are beginning to burn out and have at least one symptom, all the way to those who are completely burned out and may need to seek additional help. Across all respondents, so the very last line where it says overall, 49% of all respondents indicated burnout. This was highest in nurses at 56%. And one thing I want to note is that we've been doing burnout assessments for years. Most of our pre-COVID data was focused on physicians, so I can really only speak to that today. But prior to COVID, we knew that about 50% of physicians were experiencing burnout. In this sample during COVID, it remains at 50%. So we're not necessarily seeing spikes, at least in our data, as it relates to COVID. We aren't seeing that too much in the physician population, but that doesn't mean it's not a concern, right? We're talking about half of the workforce who is experiencing burnout, and this is something that we need to be paying attention to now before it could get worse. The other thing I will note is that burnout was slightly higher in those who were in ambulatory care settings providing COVID care. This was about 2% higher than other work settings. And that's something we can certainly talk about, but we know that burnout is usually a little higher in ambulatory care settings even before COVID. Self-reported anxiety or depression. A little over 1/3 of all respondents noted self-reported anxiety or depression. This is simply a self-reported value, so this is not a diagnostic tool. I just want to clarify that. This was again highest in nurses at 44%, followed by clinical support staff, so medical assistants, nursing assistants at 43%. This is an area we'll be keeping a close eye on in the next 6 months to 12 months, especially as things kind of go back to normal in healthcare, and whether we will start to see spikes later when sort of the adrenaline, if you will, has dissipated a little bit. And we don't have great pre-COVID data on self-reported anxiety and depression from the AMA, but still, especially in nurses, we're talking almost 50% who noted some level of anxiety or depression. We also included 2 questions in our survey around feeling valued by the organization and around having an increased sense of meaning and purpose because of being part of the COVID-19 response. 46%, or less than half of all respondents, noted that they felt valued by their organization. It was also less than half of respondents that felt an increased sense of meaning and purpose due to the COVID-19 response. Feelings of value, feeling valued by their organization, was lowest in clinical support staff at 37%, followed by nurses at 40%, and having an increased sense of meaning was lowest in our physician population. And when we did an analysis on these data, we found that these 2 factors, feeling valued by your organization and likely organizational leadership, and also having an increased sense of meaning and purpose, did serve as a protective factor. So those that felt valued, felt an enhanced sense of meaning and purpose around their work over this past year were also less likely to be experiencing higher levels of burnout and self-reported anxiety and depression. I would say anecdotally that the question around value has been very shocking for organizations to see. When they see their data and find out that less than half of their respondents feel valued, it's been kind of hard to swallow. But we would also say that this has brought a lot of low-hanging fruit opportunity for organizations to think about very small things like thank you notes or the way that they're communicating and honoring the sacrifices that their employees have made over the past year and even beyond and outside of COVID. And so we work with groups even who saw these data early on in the pandemic of people not feeling valued, adjusted their communications, found small ways to express their gratitude for their employees. And when we surveyed a second and a third time, we did see that number go up. And lastly, just a couple of additional insights around intention to reduce work hours or leave practice. About a third of respondents noted a moderate, likely, or definite chance of reducing clinical work hours in the next 12 months, or to leaving their current practice in the next 2 years. And we know from prior research, that when people say that they are likely to leave their practice in the next 2 years, they do leave their practice in the next 2 years. And so this is important both from a 50,000-foot view when we're talking about the workforce overall and who is leaving the workforce and whether we will have shortages because of that, but certainly for individual organizations when thinking about things like succession planning, if early retirements are happening or people are getting burned out and leaving, and we know that that can be very costly. So I'm going to pivot a little bit to talk really about the opportunity that I see, the opportunity that we've seen at the AMA over the past year. The term crisis, its Greek origin comes from the word crisis, and it can mean one of two things. The first is that it can mean danger or something unstable or extremely difficult. But second is that it can be really a turning point or an opportunity. And I think that is one way that we should be looking at COVID when we're thinking about the well-being of our workforce. We know that COVID has both created new issues and stressors on the workforce. It has exacerbated issues that have long existed prior to the pandemic, but it's also created an opportunity for us to reconsider this moment as one in which we can transform the way we think about how we operate and to better understand what removes joy from work and, more importantly, what gives it back. And so some of these changes will focus on individual resiliency and helping people connect to what individual resiliency means to them. But it's also time for us to re-examine our processes and our cultures and to really make wellness a core institutional value. Because if we care about patient safety and we care about quality of care, and if we care about costs, we have to care about the well-being of our workforce. And so we're really at a crossroads. We know from the SARS epidemic back in 2004 from data out of Canada that it wasn't until about a year after the initial threat of the outbreak subsided that we started to see increased depression and mental health concerns. And it was also around that time that we started to see people leave the workforce. So the adrenaline, if you will, had started to subside and there were still major issues that were left unaddressed. But we can learn from these past events. We have learned from these past events in the work that we've seen organizations doing over this past year to ensure that we have supports in place to address mental health concerns, to address burnout, and just generally be thinking about the resetting of our operations and what we can change and what we can transform given this opportunity. We know that short-term stress can turn to long-term stress injury, but it can also turn into post-traumatic growth. So we really want to harness this moment so that we can help our workforce thrive, and that wellness is just not something that we do or that we need to solve, but rather that it's a core institutional value that's demonstrated by the institutional decisions that we make. And so what could help? We asked a couple questions in our survey about things that we thought might be supportive during this time. The first was around clerical support or administrative support. So things like helping with inbox messaging, documentation, and order entry. This was a major concern prior to COVID. It is the #1 driver of burnout in physicians, and 2/3 of ambulatory respondents noted that having administrative support would enhance their sense of well-being. This was highest in general internal medicine and family medicine. If you are in one of these specialties, this is likely unsurprising to you. So thinking about things like team-based care with in-room support, training up medical assistants to take on some of this work, and really making sure that everyone is working at the top of their license. We have modules at the AMA on our stepsforward.org platform to help, especially in primary care, think about these workflow enhancements that can really help drive practice efficiencies and enhance overall well-being. Having healthy food available seems like a kind of a mushy thing, but I will say at the beginning of the pandemic, this was really important for groups, especially in the ER and ICU setting. It was just one less thing that they had to think about, especially in such a chaotic and stressful time. And so we had a lot of groups who just found ways, either through gift cards or bringing food, healthy food into the space so that people didn't have to think about where they were getting their lunch or what they were bringing home for dinner. This was some low-hanging fruit opportunity for groups, not necessarily solving everything, of course, but certainly an opportunity to be thinking about. And then personal access to mental health care. More than 2/3 of respondents noted that some level of personal access to mental health care would help them during this time. And so we've worked with a lot of organizations who are thinking about what kind of mental health supports are available to them. And are they free? Are they accessible? Do we have options that can range for people, because everyone deals with their mental health just a little differently? And I would say over the past year, we've seen kind of 5 emerging themes from groups and the solutions that they've put forward, especially during a time of crisis like COVID has been. But I would argue that a lot of these will certainly extend and be true in non-COVID times as well. And that first theme is really around meeting basic needs. And so I've touched upon that with things like healthy food. And in the beginning of COVID, it was a lot about personal and family safety and transportation and lodging. We had groups who just had small things like taking care of dry cleaning. Again, just taking small things away from people's daily needs so that the system can be taking care of those things so they can focus on other work and just feel a little bit more whole and have time to focus on themselves. Communication and leadership, obviously very important all the time, but especially during the past year. I think many of you can probably relate to, in the early days of the pandemic, perhaps getting 20 emails a day, one from the CEO, one from the unit leader, one from a department lead, one from HR, all having different messaging and not sure what to read, and so not reading anything at all. And so it was really important for groups to streamline their communications as much as possible, but also to figure out who people wanted to hear from. And this differed across organizations. Some people wanted to get the message from the CEO. Some people said, I just want to hear from my unit leader. I want to get one email a day giving me an update on what's happening in the hospital from my unit leader, and trying their best to streamline those communications so people weren't as overwhelmed. Making leadership visible, especially on things like rounding, was really important. So getting leaders on the ground, rounding, asking questions like, what do you need? And how can I help? Really made a difference for a lot of the groups that we've worked with. The third category is really around reflection and processing and peer support. We've seen peer support become more popular, I feel like, in the last year than ever before. Almost every organization that we work with has some level of peer support, whether it's informal or a formal program. And I think we're going to see a lot of organizations focusing on peer support going forward. People really want an opportunity to connect with colleagues who are going through shared experiences, to really think about what they're going through and having someone to process that with. And the last 2 categories, one around normalizing help seeking and making access easy, which hasn't always been true of healthcare, and it usually isn't around help seeking. It's hard enough to know that you need help, and figuring out where to get it is just another burden. So we've had a lot of groups find ways to streamline where people can get help and to build new resources for them. So this might be a guide or an intranet site that just brings it all together in one place so people can see, there's options for them individually, there's options for them to have one-on-one, maybe short-term counseling connections, there's options for them to have group connections, but just putting that into one place so when they feel like they need help, it's easy to get to. And we also learned that we had groups that had these options available and had streamlined the communications, but weren't thinking about things like third shift. We had a group who had opened up one-on-one counseling for folks, and it ended at 6 o'clock. They were drop-in hours, but they ended at 6 o'clock. And so third shift, nurses, physicians, whoever was around wasn't giving access to that from an equity lens. They just didn't have access to that. And so they were able to expand those hours to make it more accessible. And also think carefully about where those things are physically located within the building. So making sure there's a level of confidentiality there, since we've seen in our qualitative responses that that's hugely important for the people who responded to our survey. And then lastly, just measuring. We believe you can't change what you don't measure. And so measuring consistently to understand what people are dealing with, where they're at, so that it can inform your decision-making and any strategies you might be putting in place. We like to say that once you've seen one health system, you've seen one health system. And while some of these things can certainly be applicable to different health systems, you really need to understand what's going on in your particular organization so that you can act upon that. And so I would just leave you with the notion that as we go back to normal, how can we expect people to go back to the way that things were? We can't, and I would argue that we shouldn't. We need to reconsider our processes, our expectations, so that job demands meet job resources. We work closely with a large system out of Boston, and they shared with us that the mental model that they've adopted for this work is really one around subtraction, not addition. So focusing on things like streamlining workflows, meeting people where they're at, changing expectations about what it means to work in healthcare. We're not superhumans with no emotions, and in fact, those emotions are important and need to be honored and have space, and to really destigmatize things like help seeking. And I would also just say that this is a really exciting time in terms of wellness. We've seen more groups than ever committed to this work. I cannot express to you how many groups we've worked with, even just at the AMA, who are coming to us for the first time with resources, with a commitment to do this work. And so that's sort of our glass half full perspective on this. Again, that this is really an opportunity to start breaking down silos, building committees, and finding something that works. And I would say that there's no single silver bullet to this work. We have to be more curious than that. We have to keep being curious about this. And so if you've tried something and it hasn't worked, or you haven't yet tried something, I would just say, just try something and then try again. Because there's really no right answer for everyone right now. And so with that, I just want to thank you for your time. I also want to thank HC3 for having me and giving us the opportunity to share our work. Our burnout assessment work remains ongoing. So if you are interested in learning more about this, or you want to do an assessment and begin collecting data, you can visit our website, or I'd be happy to speak with you as well. Again, this is part of the mission work of the AMA, so it is not tied to AMA membership. And with that, I will turn things over to Molly and look forward to the discussion.
Thank you so much, Kira. Appreciate it. I'm going to ask Mark and Chris to turn on their cameras, and really looking forward to a discussion with you today to talk about some of these findings. I think it's certainly, as you pointed out, physician burnout has been a topic in the industry for quite some time, and knowing that it impacts half of all caregivers is such a startling figure to me, and a good reminder of the challenge before us. So as we get into these questions, Mark, why don't we start with you? If you'll tell us a little bit about yourself and your work at the Chartist Group, and would also love to know if there's anything in what Kira just shared that surprised you.
Okay, well, thanks, Molly. So I'm a primary care internist by training and practice, and a partner with the Chartist Group. And as the original introduction was, said that I lead our behavioral health consulting practice. Just a little bit about the Chartist Group. Our clients are primarily large academic health and community-based healthcare systems, and we provide consulting services in many areas, including strategy, operations, information and technology, communications through our partner Jarrard, regulation and physician alignment and leadership. My consulting work also focuses on physician alignment, supporting organizations in developing more effective collaboration with providers. So we necessarily then get into work with our clients around strategies focused on provider wellness. And I also want to mention that over the past year, Dr. Rick Sheff, the Chief Medical Officer of the Greeley Company, another member of the Chartist family, and I have hosted 2 day-long training sessions for physicians on addressing burnout. My specific interest in burnout actually dates back since medical school. It turns out that it was the subject of a commencement speech I gave at, excuse me, graduation. And I thought I'd share an excerpt from that speech. And then you can guess when that might be. Maybe close your eyes so you don't try to guess my age. But so here it goes. Here's an excerpt. Quote, until recently, few doctors would admit that total commitment to medicine had its personal cost. Yet the rates of suicide, alcoholism, and drug abuse, up to 8 times higher, maybe more than the general population, attest to the toll stress takes on our lives. A recent JAMA article found that the major source of dissatisfaction among primary care practitioners was too many patients to see in too short time, too large a caseload, and too much time on call. So when we give this course, I actually asked people to guess. It turns out I gave that graduation speech in 1984. So while the pandemic has certainly highlighted the importance of clinician well-being and burnout, this is not a new problem. With regard to surprises, I just want to commend the AMA. This is an amazing survey. We need this survey in the industry. A lot of the work around impact of healthcare workers has historically been actually in China and in the East, Near East, because of the fact that that's where the pandemics were. So this is really important information for us to glean, and I think that Kira, you did an excellent job of actually highlighting some of the areas. In terms of just questions about what I'm surprised at, I think that Kira actually pointed out a number of the things that actually were really troubling and surprising. One that was not on the slide, but I know is in the survey, is this question about I've been asked to do things that compromise my integrity. Although one might say 16% of people said answered positive to that, that might be low, but that's not something that's acceptable in any way. And actually, I assume that question actually was derived from other work that's done looking at moral injury, and it's really an important, and we can talk later about the distinction between moral injury and burnout, but it's a critical aspect of burnout that relates to this kind of professional sense of, or the sense that what you're doing is actually not according to your values. I think we've already mentioned the 46% that stated that their organization didn't feel, only 46% that said that the organization valued what they were doing. That's unacceptable. And also, and I think this was mentioned too, the offering of support, personal access to mental health care, less than 50%, staff support, 32%, which Kira talked about. Again, those are, as we know, are all important factors. And we'll talk later about all the multifaceted approach that needs to be taken, but those are critical factors in addressing burnout. Just trying to think if there's anything else. I think the other thing that I noted, and I kind of looked up after I reviewed the data, was this question about how does this relate to what's going on across the general population? I know that wasn't the intent of the survey, is to compare to general population, although there have been surveys in the past too, but just a couple of things to note, and then I'll hand this off to Chris. One is, the Kaiser Family Foundation did a survey a few months ago that looked at the impact of COVID on the general population and found that 4 in 10 adults nationwide expressed symptoms of anxiety or depressive disorder. And that actually is pretty similar to what we're seeing here. I think it was 36% Kira. In the Kaiser study, more women than men were facing mental health challenges. That's similar to this study. And actually, interestingly, similar to a lot of the pandemic studies that have shown, particularly in China, that women are much more impacted than men are. The percentage of suicidal ideation of caregivers, fortunately, was small here. Obviously, no number is acceptable, but significantly less than what the Kaiser study showed. So, thank you.
Thanks, Mark. Chris, tell us a bit about your work at Radiology Partners and your reactions to the survey.
Sure, thanks for inviting me. So I'm a neuroradiologist. I'm the president of an 80-person radiology group based here in North Carolina. And then with Radiology Partners, I serve as, Megan mentioned earlier, as the Associate Chief Medical Officer for Radiologist Experience. So we're now approaching 3,000 radiologists across the country in various settings, both on-site and remote. And we recently reorganized our Chief Medical Officer office into numerous different components of Associate Chief Medical Officers. And so we have folks that are focused, as you might imagine, on operations, on IT. We have somebody focused on artificial intelligence. But I think it speaks to what we're thinking about, what we're talking about here, that we decided as a practice, we would also have a dedicated office for the radiologist experience. And so thinking about, as Kira had mentioned, year after year, physicians experiencing 50% burnout. And, radiologists do a little bit better than that, although some of the other data around divorce and certain issues, radiologists do a little bit worse. And so one of the things about Radiology Partners, we, like many of the institutions that were involved in the survey, I'm sure, serve as a mission-driven organization with a mission to transform radiology. And as we go through all of the things that are happening in medicine today, to think about what does radiology look like down the road. And so, of course, we're talking again about IT, we're talking about AI issues, but to spend time thinking about the individual radiologist and how we work as teams to take care of the work that we do. And in different practices, that can be a very isolating practice to, sit in the dark room by yourself. And are you interacting? You don't have that same patient interaction, and that works well for some and not so well for others. But I've been working with some folks at Rad Partners on this particular topic over the last 6 months. And we've got a number of projects that we're looking into. We're about to launch a program in particular to look at brand new docs. So you're coming into medicine, you're starting off. What are the things that, folks like Mark and I maybe have picked up over the years and would like to share as you launch your career? Taking a look at that, and then taking a look on the other end as people are starting to wind down their career. So we can get into all of that because I think those are all important pieces in how we manage burnout. And like Mark said, I think one of the things that really stuck out is this idea that less than 50% of people feel valued by their organizations. And I know that differed a little bit depending on what the role was and all of this, but the idea of purpose is so important for what we do, and particularly as we're dealing with innovation, we're dealing with a highly skilled working workforce across the spectrum of healthcare. The idea of knowing why I'm here and what I'm doing is so important. And so we'll talk about things that we can do to help out with burnout, but I think that's definitely one of them. And Kira mentioned that folks are just shocked to find out that their workforce doesn't feel valued. So how do we address that? And we'll talk about that. The other thing that stood out to me is over a quarter of the respondents saying, I'm looking to reduce my work hours, my clinical hours over the next 12 months, and even to leave my practice within the next 2 years. And as Kira said, that if they say that they're probably going to follow through. And so what is our responsibility then, as we're thinking about organizational leaders? How do we set that up? That's not sustainable. It's not acceptable, as Mark said, in many of these circumstances that exists that way. But as we're thinking, not just about succession planning, but just about operational viability, how do we deal with the idea that we could lose a quarter of our work staff in the next 2 years? So those are a couple of things that really stood out to me.
Thank you both. Would also love to hear from you. Kira went through a number of, facts and figures, as well as potential solutions and trends that we're seeing. You just mentioned a few, Chris, there, which I also thought were interesting. Are there in your work either, and I would pose this question to both of you, we'll start with you, Mark, in your work with academic medical centers and health systems across the country, and in the behavioral space, are there parallel trends that you're seeing, that echo the results that Kira shared today, either in terms of solutions that organizations might be grappling for, or just trends in the way that physicians are presenting and experiencing?
Yes, Molly. I mean, this information is quite consistent with what we're seeing in the industry. I don't know, in terms of some of the approaches, we think about, so as Kira said, this is a complex issue. And the question becomes for healthcare organizations is what do they want to kind of bite off and tackle here, right? And the way that we kind of work through this with our clients and what we encourage clients to do, and I think it's kind of aligned with what Kira is saying, is you have to think about this as a multifaceted problem. And when we talk to clients about this, and in our course, we actually utilize a really helpful framework that we would encourage everyone to if they're not familiar with it, to look at, which is that was developed by the National Academy of Medicine a few years ago. They wrote this amazing book called Taking Action Against Clinician Burnout, a Symptoms Approach to Professional Well-Being. I'm not going to go through the details of this book in any way possible, but I do want to mention that the framework touches on various levels of intervention, which I think should be part of the checklist for an organization. So the first level at the kind of the highest level is the external environment. There's a lot of stuff that goes on that is creating imposition on healthcare organizations and providers. It's happening at a level beyond the healthcare organization's really control. And that has to do with policies, laws, regulations, right? So, examples would be payment policies or requirements around clinical documentation, which we know is an incredible dissatisfier. Quality reporting, pre-authorization requirements, we can go on and on. Those are things that probably should be on the governmental affairs checklist for a hospital or healthcare system, but not really a focus for short-term intervention. But the other aspects and the levels I think are really critical. So what can the healthcare organization do? And I think we talked about this a little bit, and I think, Chris, your organization is really a symbol of the importance of leadership, right? Your organization decided that this was a mission-critical feature or goal, right? It became a strategy. You figured out how to delegate responsibility across this. Incredibly impressive. That has to happen at every organization. It has to be part of the strategy. As the IHI Institute for Healthcare Improvement has done, they created a fourth aim, right, to address this. So one is just leadership. It's got to be on the board's agenda. It has to be measured consistently. There has to be accountability. I think then the question is at the frontline level, what are the series of interventions? And I think what we talked about is, how do you make a practitioner's life easier? We oftentimes say, how do you make it easy to take good care of patients, right? And there's, we can talk about the EHR. There's a lot of streamlining work that can be done. It sounds like, Kira, you've done a lot of work with organizations around that piece, and I think it's critical. And the final piece at the very basic level is, how do we help individual clinicians, either those who are in trouble or really need help, right? So that's the direct mental health intervention, or just general providing wellness support. So that's how we generally think about this. Don't have to do everything. Engage your clinicians around what they think is going to be most helpful for them.
Yeah, no, I think those are great points. The paper that Mark, you and Molly and Dr. Alejandro put out, you talked about a number of tactics that get there. And I think going back to this idea of feeling valued, I think there's a huge piece of just being heard. And when we start looking at the extent to which healthcare consolidation is happening, whether it be in practices, it be in health systems, as these systems get bigger and bigger, and we talk about, you know, these wonderful ideas of, you know, working at scale and buying power and all this kind of stuff, the individual person continues to get more and more lost. And so getting back to where's the space for people to be heard? Who do they want to be heard and communicated from, as Keir was talking about, and being able to identify that. So there's not, you know, as you said, Keir, there's not a magic bullet that for all of that, but these ideas of connecting back to the individuals, valuing the team, listening to what they have to say, and then following through, right? So if you're going to send surveys out, if you're going to talk to people, if you're going to do small groups, if you're going to do town halls, that's great. And you don't have to do every single thing that comes up, right? We're, you know, focus on the trends, focus on what's in the middle, just because you heard this one thing, but you've got to hear it, and then you've got to have a response and put it out. And those are one of the ways that we can start to add that value back in, that I think is really a powerful tool to counter the burnout.
Thank you. Yeah, and you alluded to that in your opening comments about the, you know, how to help physicians feel valued. That was something I was going to ask you. So thank you for sharing that, and certainly I appreciate those comments. We talk about follow through a lot in our world as well. So it's, you know, and each of you have touched on communications, but it's important to communicate, to listen, to engage, but, you know, follow through is also pretty critical. And I think, no offense to both of you or either of you, but physicians are particularly sensitive to wanting to see follow through. That goes a long way with them, and they're very detail oriented. Thank goodness.
And I think they're very detail oriented, and they want that. I think one of the things, and you tell me, when, you know, a physician comes forward and says, well, I have this issue, and then they're expecting that answer. But if they're kind of out on the edge, we may not, as an organization, be able to address that directly. But we do need to see where the trends are, and we do need to be accountable for what we can do, and then we need to do those things. So we also have to a little bit of a strategy for making sure that, you know, we're recognizing some of those outliers that we may not be able to address immediately, but also giving value to their concern.
Yeah, absolutely.
And I would just add, if I can, just transparency and sharing the data that you have as much as you can. Certainly follow through for sure, but also just in sharing those results. We encourage every group that we work with that you don't just like keep them in your committee and no one ever sees it again, but that you're doing rounds. You go to each department and say, here's what we're seeing. What else can you tell us? Hey, we're not going to be able to do everything in this first year, but it's really important for us to hear from you. So sharing that transparently with those that work at the organization. And then again, just to emphasize Mark's point around making sure leadership is involved in that conversation. And leadership includes the board, making sure that it's a board item and that there is some accountability at the highest level of leadership. Groups that have that, we've seen, are much more successful early on in getting this work in place and finding the resources, because this is an investment. It's a worthy investment, but getting those resources in place early.
Yeah, and I can share anecdotally, you know, just within our 70, 80 person group, as we got into the pandemic and we couldn't meet together, we're moving to all these virtual things. We started to explore other ways to get to folks. We employed a new survey. During our virtual meetings, we did some breakouts. We gathered this data, and then we did exactly what you're talking about, Kira. We came back and we said, here's what you said. And then we came back the next month and said, here's what you said, here are the themes, and here's what we're going to do about it. And then we came back the month after that and said, here's what we're going to do about it, and here's our progress so far. Here's the thing we can't get to. And I can't, you know, again, a little bit anecdotally, but I can't tell you how much that was appreciated. And even when we're, you know, so far away from one another, people really felt like, hey, somebody's paying attention, they're listening, and it added the value back. So that's challenging on a health system level. It's challenging on very large levels. But again, as you're saying, as you get into these subgroups, thinking about some of these strategies as ways to let people know that we're hearing and then doing something about it, and we're not just waiting around.
Yeah. I wanted to add that measurement, I think we've talked about, is very important. And there are tools out there that I think we encourage healthcare organization leaders to use because they're well validated, they're reliable. I know you took a piece of the Mini-Z, which I think had been initially developed with the support of the AMA.
Yeah, we do use the Mini-Z overall, even outside of COVID.
So beyond that one question, right? Is that right? Yeah.
Yeah, that's
and I
correct.
think the advantage of using that kind of tool is that you can, first of all, you don't have to create your own. It's actually statistically valid, and also that you can track your progress over time to see how you're doing. And if you want, you can benchmark against other organizations. If you're in a large healthcare system, you can benchmark across multiple medical staff. So it's a really important part of the commitment is ongoing measurement, because can't take that for granted. I've been in organizations where they say, yeah, we did a survey a few years ago. We kind of did a few things. It's kind of fell off our radar screen. That is a message to providers, particularly, that it's not as high a priority as they may think it should be.
Mark, you talked a little bit. Go ahead, Kira. I'm sorry.
I would just share that in our burnout assessments pre-COVID, and we're still doing Mini-Z burnout assessments right now, we ask organizations for a yearly commitment. So groups come back to us yearly around the same time to measure so that we can help them see change over time. So I'm just putting an asterisk to that point, Mark, that absolutely couldn't agree more. Having regular assessment and data to use to drive your strategy to have informed decision-making, very, very important.
Kira, along those lines, it's about 1:45, so just to do a time check here, we've got 2 questions in the chat. Would invite anyone else to share questions. We'll leave a couple minutes at the end for those. But Kira, I wanted to piggyback on something that you just said and that you touched on in the survey. So, in many ways, COVID has in healthcare, I feel like what we see and hear a lot about is it has produced these incredible moments of opportunity to do things differently, like these teachable moments, that maybe we've been working at for a long time in healthcare to get to. And by way of necessity and the response that we've had to COVID as an industry, we've learned so much about, what works, what doesn't, but maybe more importantly, what works going forward on systematic issues that we've been dealing with in healthcare for a long time, physician burnout being one. So I'm curious if you would talk a little bit about, and Chris and Mark, I'd invite you to weigh in on this too, if you would like. What are the long-term impacts of COVID on physician burnout, and how do you think it will change the course of how the industry grapples with this issue, or maybe I should say addresses it going forward?
Yeah. I think first and foremost, we're seeing people thinking and talking about it. And we were not always seeing that in a pre-COVID world. Again, as I shared in the presentation, we have worked with organizations over the past year that we had never heard from before that were actively not doing this work. And so it's been exciting to just see them come to the table and to acknowledge that this is important and that their leadership is ready to invest in that. So I just want to emphasize that point, that our pre-COVID starting point was not even talking about this issue. And we've seen, even having a webinar today about this issue going forward, I think we're going to see a lot more organizations have a commitment to this work and find resources to do it. I also think we've seen from just leadership that they understand that this is an investment and that we know that burnout is costly. Replacing one physician at an organization can cost upwards of $1 million. And so if you find resources to bring on a staff person, 2 staff persons to head up a well-being committee for your first 1 to 3 years, there's ROI if you just prevent one physician from leaving your organization. And so really thinking about that as an investment, that it's not just, I need to find dollars to support a well-being committee, but that there is ROI there. And I think the narrative around that is changing. And we've seen that change over this past year because it's been more public than ever, especially when you think about just news media and what healthcare workers have had to deal with. I hate that it was a pandemic that had to cause that awareness, and yet we're seeing it, and therefore people are paying attention. We need to use this moment to continue to build and harness that energy. And then I think measurement. Again, we've talked about measurement here, but I do think that more organizations understand that they need data to do this work, that this isn't just let's have a yoga class and we can check the box on wellness. And I don't even mean that facetiously. I think that a lot of groups have often thought about wellness as let's have yoga and mindfulness and then we check the box, but wellness is not a check the box thing. As I've shared, it needs to be a core institutional value. And in order for us to do that, we need data. And so even just having the COVID survey available at the AMA, and I know groups have used other surveys and all of that's good. I'm glad that people are measuring. And I hope that people will continue to measure in the future and to use those data to drive decision making. And really can't emphasize that enough. I think one curiosity of mine, and I'd love to hear thoughts from Mark and Chris on this as well, is the integration of mental health into this work. You know, burnout is distinct from a mental health diagnosis, and sometimes the two can get conflated, and it can be hard to pull out those pieces and know when some additional support is needed from a mental health lens versus the system drivers of burnout. And so I know that's something we're grappling with a bit at the AMA, and I don't have an answer. That's more of a question, and would love thoughts from my colleagues on the line with us. If you have any thoughts about the mental health burnout dichotomy that we see.
Well, first of all, there's I recognize that it's talked about separately, but it's definitely related, and we know that.
Absolutely.
So, and not to simplify this, but you know that it was 46% of people thought that they had access to mental health resources. That's unacceptable. And you know what we're seeing is however people see digital behavioral health or telebehavioral health, what we're seeing right now is an acceleration of the availability of access to resources that never were available before. So healthcare organizations, just as large tech companies, are contracting with telebehavioral health companies and giving people direct access to care. And I think that is one important innovation that needs to be accelerated.
Yeah, a couple of things, Kira. I think I liked your slide. You talked about crisis and even spoke of the Greek origins, which is always a highlight. So, but this is to see that the burnout number hasn't changed specifically, but that we're now having different conversations. So I think this is sort of the moment. And then you talked about the SARS as well, that it was sort of a year later that we started to see some of these things. So I think, Molly, to your question of what are we going to see from COVID, I think one of the biggest things is it's just putting a spotlight on what we have, and it's created a time for us to have the conversations. So let's have the conversations, and we're here. I think we need to really examine the experience. What did we do in the middle of this when our back was up against the wall? Let's look at what we did well. Let's celebrate that. Let's make sure we're supporting that and go forward with that. And then let's be honest about where we failed. What resources did we recognize? Have we taken the time to look back and say, gee, if I could go back to, March of 2020 and better prepare for what was coming in April and May, what would I have wanted in place? Who would I have wanted in place? Okay, great. Let's do that now. And then how do we reorganize to continue to be more resilient going forward? And the last piece I would just add, you talked about, a lot of the focus in the past has been on individual wellness. I think those things are key. I think learning, how to calm our minds and be focused and, be a little bit more resilient psychologically ourselves is all very, very important. I think a growing recognition of what we need to be doing organizationally in terms of giving people the appropriate level of autonomy, in terms of being able to talk about the purpose and the mission to add this value to make up for that deficit that's there, and giving people the opportunity to work at the top of their license and to develop themselves professionally. That's the responsibility of healthcare and non-healthcare, for that matter, leaders that we have to be ready to take on as well, beyond just, hey, we'll give you some tools, go do this on the weekend yourself. So thanks for bringing that up.
A couple of questions in the chat here, in addition to Chris, your glasses getting a shout out from your colleague, Rich. What instances has the panel seen in terms of successful efforts to address organizational sources of frustration, stress, and burnout, including, and these are the ones I hear a lot about from physicians, lack of control, insufficient reward, so financial and intrinsic, absence of fairness, and work overload? Big question.
Yeah, it's a big question. So no answer will actually be able to satisfactorily address that. But I have to say, and I think this is part of kind of the discussion around how to make this sustainable, is and we've talked a lot about the organizational commitment and the importance of the board being on board and resources. There needs to be a structure in place to make sure that this is something that is somebody's accountability or some group of people's accountability. So we're seeing, wellness committees and chief wellness officers, and what Chris has talked about, and as we talked about before, is delegating responsibility, ask parts of the organization to really look at this. And I think that's the only way that this can stay on the radar screen and be addressed over time.
Yeah, and I think, so having the organizational communications, putting the resources in place, the insufficient reward question, I think a lot of times we get caught up in direct cash compensation, but when we start talking about bringing in a teams-based approach, bringing in additional resources, if you pay me the same, but you make my job more enjoyable each day or more satisfying, or I can professionally do what I wanted to do, oftentimes you can't pay me enough to continue to go through the indignity of doing the other things. So I think we get lost a little bit in where we should be applying those dollars. Not to say that we shouldn't have fair cash compensation for everybody at every level of the organization, because we need that for sure. But I think those are some of those things. And then as Mark said, that you've got to have the next year's survey, and you've got to be able to say, here's what we did. Okay, here's what we hear now, and here's our next step, and continue that conversation. So I think all those things lead to better successes as we continue to move forward.
Yeah, just one quick thing is just to add to this is just work-life balance is so important, and it's been sacrificed, right? And that's where that problem. So just to Chris's point, the problem is not the answer, oftentimes, unless major inequity. It's really thinking about how to make professional lives more satisfying.
We'll do a little speed round here, and I'm going to attempt to fold two questions into one. We have a little bit about a question about the fear factor, and just saying it's hard for providers to talk about, for fear of discussing mental health issues. It's hard for them to talk about it because of the impact potentially on their licensure. And then there's a question here about if you do suspect that a physician colleague has burnout or is acting differently, how should physicians respond? So I'll throw those two out there in our last few minutes here together.
So Mark's the professional. I'll throw one thing out and then turn it over to Mark here on this, but we've been expanding coaching circles throughout our organization, 6-month time frame, meeting for an hour twice a month, small cohorts with trained coaches that are colleagues even, that just create a space to have some of these conversations. And that has been, those who have participated, widely successful. I think just learning how to have the conversation so that when you suspect that, you can start yourself to have a conversation with that person to say, hey, it looks like you're having a hard time, and move forward with that. I think there does need to be a point where you can escalate that to somebody who can get more help if you're seeing severe symptoms. But interested to hear what Mark has to say about that.
Yeah, no, I agree. That's, again, terrific to hear that your organization is doing that, Chris. There's also external organizations. There's an organization called PureRx Med, and that actually, Kira, you're familiar with it. That creates a buddy system. Obviously, all of these kinds of endeavors need to respect confidentiality. It's terrific if you can create something like what Chris talked about, because one of the problems has been we've lost the ability to connect with our colleagues. Given the pace of our work, given the fact that many of us don't come to the hospital anymore. So the extent to that you can create those opportunities is terrific. And I believe that all state medical societies have resources available for practitioners that need that kind of help, and certainly can reach out to them if you need support.
Excellent. Thank you all for your time and all of your expertise. Megan, I'm going to kick it back over to you.
Well, wonderful. I think we could keep talking about this, but we're not going to burn ourselves out on this subject. So thank you, Molly, for leading this discussion, and many thanks to Kira for sharing your wonderful and thoughtful presentation, and Chris and Mark for sharing your perspectives and what your organizations are doing. It's inspiring as we come out of this year to think about how we really do this correctly as we come out of this difficult time. So thank you all for being here. This recording is going to be shared in the next few days on our website. I also encourage you to visit our website, hc3.health/events, because you can register for our next installment of this event, which will be taking a deeper look at the patient experience. And I just want to thank everyone once again for your time today and for spending your afternoon with us. Have a wonderful day.